One way the USMLE can test the sympathomimetic drugs is with a blood pressure and heart rate graph. So here we see our two graphs, one that's going to measure our blood pressure and the other takes a look at the heart rate. The top line on the blood pressure graph is going to measure the systolic pressure, while the bottom line is going to measure our diastolic pressure. So here's our baseline reading for the patient. Now we're going to give some norepinephrine. Norepinephrine is going to have alpha 1 effects that are going to be greater than beta 1 effects. So I'm just going to write that out. Has alpha 1 effects greater than beta 1 effects. Alpha 1 is going to raise the diastolic pressure by increasing vasculature resistance, meaning we're going to clamp down those blood vessels. Now, beta 1 effects have inotropic effects, which should raise our blood pressure, and they also have chronotropic effects, which should raise the heart rate. Well, that's not what we see. The increase in blood pressure triggers the body to compensate by decreasing the heart rate in a phenomenon known as reflex bradycardia. So we would think that activating our beta 1 receptors after we give norepinephrine, that should raise the heart rate. However, since our blood pressure is going up, we're going to get some reflex bradycardia. So why did the heart rate just drop? Well, even though we have the direct stimulation of beta 1 receptors, which should increase the heart rate, the bradycardic reflex overcomes this and produces a slower heart rate. So now we can consider a different drug. Let's look at Isoproterenol, an isolated beta agonist. So here's our baseline reading, we give some Isoproterenol, and we get some sort of effects. Remember, Isoproterenol was beta 1 is equal to beta 2. So the beta 2 effect is going to lower our blood pressure with the decrease in the diastolic greater than the decrease in the systolic. This is because, if you remember to our discussion about beta 2 activation from earlier, beta 2 receptors causes vasodilation. The beta 1 effect is going to increase our heart rate and temporarily increase our systolic blood pressure. So we just kind of talked about the beta 1 effects over here. We're going to get the expected result over here. However, the increased heart rate reduces our ejection volume, and therefore the steady state systolic blood pressure will be slightly lower than what it was prior to the administration of our isoproterenol. So we're going to actually have a slight deflection. Now, we have something called the beta 1 reflex. The increase in heart rate is significant because in addition to the beta 1 effect, which causes an increase in heart rate, there's also going to be an element of reflex tachycardia due to this overall drop in blood pressure. So we have many different effects going on at the same time. You should be able to look at these charts and interpret results like this. And to do this, you'll need to have a solid understanding of what activation of the alpha and beta effects are, and then how they're going to actually affect the heart and blood vessels. We just talked about our sympathomimetics. Now we can shift to our sympatholytics. So what are the sympatholytics? Sympatholytics are drugs that are going to inhibit postganglionic functioning of our sympathetic nervous system. And before I talk about these, I want to briefly touch on alpha 2 receptors one more time. So do you remember what the action of stimulating an alpha 2 receptor was? Well, recall from earlier that alpha 2 stimulation is actually going to decrease sympathetic outflow. So even though these drugs stimulate the alpha 2 receptor, they're going to actually inhibit sympathetic outflow from our sympathetic nervous system. So we can demonstrate this visually. I can tell you that the sympathetic hormones are going to be created in our adrenal gland. Remember, those are the catecholamines. If we activate our sympathetic system, we'll get more catecholamines released into the bloodstream. Now, if we introduce an alpha 2 receptor stimulator, or an agonist, we're going to decrease the amount of catecholamines that are going to be produced from our adrenal gland. So we have less catecholamines that enter our bloodstream, which is ultimately going to lead to vasodilation and thus a reduced blood pressure. So let's take a look at a couple drugs that act on these alpha 2 receptors, and that's going to include our clonidine and alpha-methyl dopa. We'll start off with clonidine. Clonidine is primarily a psychiatric drug used to treat ADHD and Tourette syndrome. It can also be used to treat high blood pressure, especially in patients with renal disease because it does not decrease renal blood flow. However, clonidine is not going to be a first-line antihypertensive agent. A clonidine overdose can present with bradycardia, hypotension, respiratory depression, CNS depression, and meiosis. And let's just think about it. If you shut down the sympathetic outflow, you're going to see all of these symptoms. And then when will you see alpha-methyl-dopa? Well, this is a fairly popular drug that you'll see on your OBGYN clinical rotation. Alpha-methyl-dopa is a drug used to treat hypertension during pregnancy. An overdose on this drug can cause lupus-like symptoms and a positive direct Coombs hemolysis. Do you remember what the Coombs test is, the direct Coombs test? The direct Coombs test, also called the direct antiglobulin test, will test for any antibodies on the surface of a red blood cell. So here's our red blood cell, and normally the body does not create any antibodies towards their own red blood cells. It would make sense because we wouldn't want to harm our own red blood cells. However, if our body does create some antibodies against its own red blood cells, they'll kind of appear like this, and we will get some hemolysis, because remember, our body thinks that these red blood cells are now foreign objects. So we take a sample of blood from this patient and we add some anti-human antibodies. So I'm going to represent it as kind of this red square just so we can keep things separate. This red square is going to be our anti-human antibody. Now, these anti-human antibodies are going to attach to our human antibodies on the surface of the red blood cell. If our body is functioning normally, you'd expect that there would be no antibodies on the surface of our red blood cell. There will be no agglutination in a normal situation. However, like I have drawn out here, if there are antibodies on the surface of a red blood cell, these anti-human antibodies will cause red blood cells to clump together, leading to agglutination within the test tube, leading to a positive direct Coombs test. So, bottom line is alpha-methyl-dopa can cause our positive Coombs test here. Continuing our discussion on the drugs that affect both the alpha and the beta receptors, we're going to encounter our alpha and beta blockers. But for now, we'll begin with our alpha blockers. These drugs do exactly as their name implies. They block the alpha receptor. There are three main categories of our alpha blockers. Here we see our non-selective agents, but we also have alpha-1 only blockers and alpha-2 only blockers. Our non-selective alpha blockers are going to equally block both our alpha-1 and our alpha-2 receptors. Now our non-selective agents include our phenoxybenzamine and our phentolamine. Phenoxybenzamine is an irreversible alpha blocker, meaning high levels of catecholamines cannot overcome blockade. How is phenoxybenzamine used clinically? Well, phenoxybenzamine is used during a pheochromocytoma resection. A pheochromocytoma is a tumor of the adrenal medulla, which produces a large amount of the catecholamines. So here we have a normal kidney and adrenal gland, and then we have a spiky hair afrotumor, which is going to represent our newly developed pheochromocytoma. A patient with a pheo is going to present with symptoms of a ramped up sympathetic system. Symptoms could be high blood pressure, heart palpitations, anxiety, sweating, or even in this situation, headaches. So we now need to treat this patient's pheochromocytoma. Phenoxybenzamine is given prior to surgery to block the alpha receptors. So here's our cell. We're going to have an alpha-1 receptor and an alpha-2 receptor. Our phenoxybenzamine, which we give prior to surgery, is going to knock both of these receptors out. So when the catecholamine secreting tumor is going to be removed or resected, any accidental surge of catecholamines that get released into the bloodstream are not going to have an adverse effect on the body. So side effects of our phenoxybenzamine are going to include our first dose, orthostatic hypotension, and reflex tachycardia. Phentolamine, which is a reversible alpha blocker, is used for patients to prevent MAO inhibitor/tyrosine adverse interactions. Remember that people taking MAO inhibitors should avoid foods that contain tyramine, like cheese. This is because MAO inhibitors prevent the breakdowns of our catecholamines, so these patients shouldn't consume tyramine-rich foods such as cheese, which will further increase our catecholamine synthesis. With our non-selective alpha blockers out of the way, we can now move on to our selective blockers. These selective blockers are like picky little children. They don't want to eat everything on their plate, they just want to eat only the alpha-1 receptors to block. So how are alpha-1 blockers named? Well, our alpha-1 antagonist drugs usually end with osin, and these include our prazosin, terazosin, doxazosin, and tamsulosin. So recall that alpha-1 receptor stimulation mediates vascular smooth muscle contraction. So we have some alpha-1 receptors which are going to be located on our blood vessel here, and when activated, these alpha-1 receptors cause vasoconstriction, which leads to a high blood pressure. So it makes sense that the application of alpha-1 selective blockers is going to be in the treatment of hypertension. This can also be used to treat urinary retention in BPH and also post-traumatic stress disorder. The side effect for alpha-1 selective blockers includes orthostatic hypotension, usually first dose, dizziness, and also can cause headache. Hopefully now I've driven home the fact that alpha-2 stimulation decreases the sympathetic outflow. So if you block alpha-2 receptors, it'll actually lead to an increased outflow of catecholamines. Mirtazapine is an alpha-2 selective drug that is used to treat depression. Toxicity includes sedation, an increase in serum cholesterol, and an enhanced appetite. We will now see how well you are paying attention. We have a 40-year-old hypertensive male who now complains of urinary retention from BPH. What medication will treat both of his diseases, both the hypertension and the BPH, causing the urinary retention at the same time? So we just discussed that alpha-1 selective blockers, or remember those drugs ending in osin, can be used to treat both high blood pressure and urinary retention from BPH. The concept of epinephrine and phenylephrine reversal is important when talking about alpha-blocking drugs, and it's going to be commonly tested on the USMLE. These graphs will make you apply multiple concepts to figure out what's going on. It also demonstrates the effects of an alpha blocker like phentolamine on blood pressure responses after epinephrine and phenylephrine are given. Here, I'll show you what I'm talking about. So in the first of these graphs, we'll focus on the drug epinephrine. You can see in this graph that the epinephrine response before blocking the alpha receptors looks like this, while after blocking the alpha receptors looks like this. So we'll talk about what's going on. But first, can you name the two non-specific alpha blockers that we just talked about? Hopefully you were thinking phenoxybenzamine and phentolamine. So from earlier, we saw that epinephrine, the drug that we have here, is going to affect our alpha-1, our alpha-2, our beta-1, and our beta-2 receptors. So here we see a large dose of epinephrine given before alpha blockade. The blood pressure is going to increase because the epinephrine stimulates these alpha-1 receptors, causing our vasoconstriction. Notice that the alpha-1 effect, the vasoconstriction, beats out our beta-2 effect, which is vasodilation. Thus, the net effect is going to be an increase in blood pressure due to our vasoconstriction. Now let's take a look at epinephrine after we block alpha receptors. The rise in blood pressure seen with epinephrine is going to be reversed in the presence of phentolamine, a non-selective alpha blocker. This is because phentolamine is going to block our alpha component, or the vasoconstriction component of epinephrine, which is going to leave the vasodilation response, or the vasodilation component of our epinephrine. So we're actually going to see a drop in blood pressure. So let's clear that off and do another example. We have phenylephrine this time, and it acts primarily on alpha receptors. So remember, our alpha-1 is greater than our alpha-2, but there is going to be no beta effects. So like epinephrine above, our phenylephrine is also initially going to have an increase in blood pressure due to its alpha effects without any blockade. However, it's going to be a pure alpha agonist. So when phentolamine is added, after our alpha blocker is added, the blood pressure is going to be normalized, but there's going to be no hypotensive effect, which we saw in epinephrine, because remember, there's no beta effect component that can still remain. These details are important to know because a lot of the USMLE Step 1 pharm questions will test your knowledge of what meds act on what receptors and how different medications can interact with one another, as we see here.